Hello, everyone. So now we come to the second part of the talk on fluorescein angiography, and this one is on fluorescein angiography in diabetic retinopathy, because diabetic retinopathy is one of the most important vascular conditions that we uh, deal with on a day-to-day basis. So diabetic retinopathy, it's the most common microvascular complication of diabetes and is a marker of the concomitant complications which are happening in all the organs of the body. But this is the only visible area that we can see the vasculature. So what happens here is an early and selective loss of pericytes, thickening of the basement membrane, loss of interendothelial cells, tight junctions, and increased vascular permeability, which leads to microaneurysms, capillary occlusions, loss of endothelial cells. All this is happening, and this is what leads to the changes that we are talking about that will occur in the fluorescein angiography. So, what is the role of angiography in diabetic retinopathy? It's one of the only ways to directly assess vessel leakage and retinal perfusion, basically to correlate the functional aspects in relation to what we are seeing inside the eye clinically. To assess the retinal blood flow, you could assess the arm retina time, which we discussed in the first part, to identify the subtle lesions like microaneurysms, irmas, NVEs, which manifest once you give the dye, to classify diabetic maculopathies in terms of focal, diffuse, ischemic, and the role in diabetic macular edema enables precise targeting of leaking aneurysms and do focal laser to those areas which are there. So to detect the presence and extent of NVD and NVE and quantify the leakage, we delineate areas of CNP, capillary non-perfusion, ischemia, and we decide on how much laser to do, where to do. To assess effect of treatment on the patient's lasers that we do, and we complement the lasers along with the anti-VEGFs nowadays. Also, when patients have conditions like asteroid hyalosis, where we cannot see clinically the fundus very well, angiography bypasses the obstructions and gives us a pretty fair view of the fundus and lets us know how to move about with the treatment. Also, the importance of wide field angiogram. The traditional, today, most of the cameras allow us to do wide field angiography. So, what you see in the posterior part or a smaller area, once you have wide field, you can actually see much more peripheral changes which occur. And these are vascular conditions where a lot of changes happen in the periphery, which we cannot see unless we do proper wide field imaging in these cases. And you can see the difference of what you see centrally versus what you are seeing peripherally, which you may miss otherwise if you don't see. So this is ultra wide field angiography when you go beyond 100, degrees in the peripheral examination, and you see the junctions of the capillary non-perfusion areas from the perfused non-perfused, and helps you decide on all the timing and how much laser to do and how extensively to treat these cases. So the stages of diabetic retinopathy clinically is mild non-proliferative diabetic retinopathy. We might see all these microaneurysms, hemorrhages, exudates, cotton wool spots in these cases. And then you go to the moderate non-proliferative diabetic retinopathy, where there would be more severe hemorrhages, mild irmas or marked venous bleeding less than one quadrant or cotton wool spots which are there. When you go to the severe non-proliferative diabetic retinopathy, you could have one or more of the moderate irmas in more than one quadrant, significant venous bleeding in two quadrants, severe hemorrhages in all four quadrants. And then you go on to the moderate proliferative diabetic retinopathy, which has features of the non-proliferative, and then there are new vessels on the disc or elsewhere, and there could be extent of insufficient areas to meet the high-risk PDR criteria. And the high risk is, of course, when you have florid new vessels which are bleeding and causing hemorrhages in all the planes of the retina. Now, these classifications are fairly clinical, but we're just trying to show you the correlation of fluorescein angiography in sync with what you see clinically, and it just helps us confirm the diagnosis. And always, fluorescein will give you much more information than what you see clinically when you are actually treating these patients. So the signs of diabetic retinopathy we just discussed, and you see all sorts of changes that happen in terms of the CFAN, like NVEs, the collateral formations, the IRMAs, the junctions of capillary non-perfusion, the various CNP areas which are there in these cases. Microaneurysms are small saccular outpouchings of the capillary network, and you see them all over the place. Tiny distinct hyperfluorescent dots, same size and intensity throughout the angiogram is how you see them. It's like a star-studded sky that you see these microaneurysms in most of the diabetic retinopathy patients that when you do an angiography in. Then there's retinal hemorrhages. You could have superficial, deep, mild pinkish color to darker ones, and some would mask the fluorescence, and you have to distinguish them from capillary non-perfusion while correlating clinically in the area. This is capillary non-perfusion, while some small patches might be blockages because of the hemorrhages, because you can correlate what's happening clinically here. Then there's exudates which develop at the junction of normal and edematous retina. They are composed of lipoproteins and lipid-filled macrophages within outer plexiform layer that you see here. So here again, you correlate the angiogram with the areas of where these exudates are, and at times you can laser the microaneurysms in the center of the circinates if they are not on the foveal region or away from the capillary non-perfused area of the FSA. Then there's cotton wool spots, accumulation of the neuronal debris, ischemia, sign of an ischemia, disruption of the nerve axons that you see these whitish areas, and they signify ischemia. And you can see the corresponding areas of masking because of the exudates and the angiogram. Venous changes, you see is dilatation, tortuosity, looping, beading, sausage-like segmentation. All these are changes seen on the FA apart from the junctions of perfused and non-perfused retina. Intraretinal microvascular abnormalities, IRMAs. You see these shunts bypassing the capillary beds and these small changes. And of course, the NVE, which is strongly seen here. You see the fine shunts taking place on the angiography here and leakage from the NVE in the late phase. Signs of proliferative retinopathy, new vessels on the disc or elsewhere. You see neovascularization elsewhere. You see them all over the area on the arcades, most common sites as you go either on the disc or as you go on to the arcades temporarily. Preretinal hemorrhages, which are seen or retrohilar or intragel hemorrhages, they'll show you a corresponding masking which is there as we look at them clinically and compare them angiographically. Then, of course, a tractional retinal detachment, which is seen much better clinically, and it may show up as diffuse leak happening from the edges and where the retina is pulled, so the vessels may be tortuous. And of course, the angiography would show you many more changes of ischemia apart from that area. Then we come to maculopathy, which is an important part because it affects the central vision of the patient, and you could have ischemic maculopathy where you see non-perfusion areas. You could have tractional maculopathy where you have the hyaloid or some membranes which are pulling the retina, like vitreomacular traction or a spanning hyaloid which might be causing traction. And then there would be a diffuse edema which is there. So the traction is an area which would require a different sort of management, while a cystoid edema, which is there without ischemia, would have a different management. And ischemia means bad prognosis because there's no perfusion there to help the visual potential in that central area. Causes of vision loss in the diabetic retinopathy, most commonly the diabetic macular edema and ischemic maculopathy, which are there. So the leakage from microaneurysms and dilated capillary segments lead to this diabetic macular edema. OCT shows you a very nice cystoid change, which is how we diagnose most of the times. FA will show you a petaloid appearance corresponding the edema which is there. Focal maculopathy is a well-circumscribed retinal thickening, which you see something like this, a circinate with a multiple isolated or ring of exudates, and you can go and laser the center of this ring and it would stop to leak and the ring may collapse once you have lasered it. Areas of individual cluster of microns which leak into the late phase, causing late hyperfluorescence due to leakage. with good macular perfusion noted. Once you have diffuse maculopathy, it is much more diffuse. You'll see it much more spanning. It is no more focal or concentrated to one particular area, but it spans a larger area. Of course, when you do angiography, you'll see the whole spanning area of leakage. Poorer prognosis cannot be lasered per se that easily. In the past, we used to do a lot of grid laser, but today I think for these we stick to anti-VEGFs or steroid injections to reduce them, and then maybe look for areas which could be lasered at times. Ischemic maculopathy means that the perfusion is gone. You can see that the foveal avascular zone is compromised. It looks larger and enlarged and is not a good sign in the long term for visual prognosis. Traction maculopathy, we discussed when we were comparing, it's a physical mechanical traction and it needs surgery to be done, and then you could complement it with anti-VEGFs or laser during surgery, but the mainstay would be surgery in these cases. A word about OCT angiography. It's an extensive area, but I'll just briefly go over it in relation to the diabetic retinopathy since it's an important aspect. OCTA is without the dye that we are able to see some of the perfusion status of the retina. And can it replace FFA today? Well, for some aspects, yes, but I think FFA is still required for a lot of clinical purposes. Just to briefly discuss with you, I think the main area in diabetic retinopathy that it may help would be the macula, to look at the foveal avascular zone, and that's where you can, if there's an unexplained visual loss and you're looking at the cause because media is clear but the vision is less, so you can do OCT angiography, and if you see that the foveal avascular zone is compromised, it tells you why the vision is less, and you don't need to inject a dye to find that out. So I think is the most important area where OCTA can be used instead of fluorescein angiography. But OCT angiography is still evolving. We are not able to see the extreme periphery as well as the central part, although now there are new devices which are allowing us to see the periphery. But we still rely to a larger extent on angiography for peripheral aspects. Once again, an example of a laser PDR which has macular ischemia, and once you do the angiography, you see this whole ischemic area. This is comparative OCTA, which is what we was discussing, that this is a good tool for just looking at macular ischemia per se. Another example of the same, that you see the OCT, and then you also look at the FA, and you look at the OCTA, and you can get very comparable images on the OCTA without injecting the dye in these cases. And at times, small fronds of NVEs or vasculature in the posterior pole area, you can also catch it quite well on the OCTA in these circumstances. So a few cases describing, I mean, whatever aspects that we've just learned, the different interpretations that are there, we'll just go over some cases where we can see practically what's happening with these situations. And this is a case you can see that both eyes on the OCT are showing you an edema. And then when you do the angiography and you go to the wider fields, you can see the extent of the diabetic retinopathy which is there. You of course see the macular edema, which you had noted already with the OCT, but you also see the whole peripheral changes of how the fronds are leaking in the periphery, and it tells you that the patient needs aggressive laser and injections to stabilize this retinopathy. This is the other eye, and you can see the similar kind of picture that on the macular area, which is a diffuse cystoid petaloid appearance, and then you see the fronds in the periphery, which warrant treatment. Now, this is a patient with moderate NPDR with no edema on the OCT scene. And when you do the angiography, you can actually see a lot of microaneurysms which are coming up, like which you were describing as the star-studded sky. And then you can see manifestations of some NVEs also, and irmas which have come up in these cases. So fluorescein will give you much more information, while clinically you may think it's a much more dormant case. This is a lasered PDR with fluorid NVEs that you can see. You see the laser marks here are probably still inadequate, and this tells you that you need much more laser and then to regress all these areas. In these cases, one has to be careful about injecting anti-VEGFs, because when you look at this kind of a florid area, when if you give anti-VEGFs and this contracts, it may suddenly cause a break, secondary break, lead to a detachment or pull the macula, and one has to be careful about injecting anti-VEGFs in these cases, and one should do more laser to regress them. This is a case with a chronic DME that you see on the OCT on the right eye, and the left eye shows you some subfoveal fluid, and this is the angiographic picture of these areas, large areas of ischemia that you see, hot disc which you see here, and the areas on the left side which are seen again areas of a lot of NVEs which have come up along with macular changes. PDR with multiple areas of NVEs that you see here, and the OCT here. And then when you see a whole wider picture of this, you see how much extent of the damage is there, uh, seen much better on the angiogram in terms of the interpretations in total. This is the case of an asteroid hyalosis where the view is obstructed clinically and one cannot assess or classify these cases very easily clinically. And the angiogram will penetrate and show you changes like these. So the angiography lasers are able to bypass the asteroid hyalosis and show you a much clearer picture of these cases. Then, of course, there's this tractional component. There, you need to do surgery to make a difference to these eyes. You also need anti-VEGFs as preparation because they may bleed a lot. So you need adjuncts of that. But when you do an angiogram in this case, you can see the full extent of the damage. Of course, the right eye needs a lot of laser and regression so that you can save what is there or save some of these eyes from neovascular glaucomas. Even if they have potentially very low vision, they go into neovascular glaucomas, which create a lot of damage in the long run. This is a case again with a large pre-retinal hemorrhage which has occurred in the left eye. And when you do the angiogram, you see the masking hypofluorescence as well as the fluorid leaks, which is hyperfluorescence. So all these changes of interpretation that we discussed in the first part are seen very well in these cases. And then once you do the angiogram and you see them, you decide the management of treatment, of how you proceed with them. And you can see that uh, the regression after treatments, the right eye was treated with lasers and anti-VEGFs, the left was treated with surgery and a 360 PRP done during the surgery. And you can see the regression in both taking place with time. And this is how the treatments have to be customized for each eye, and the angiography helps us do that to a large extent. Some of them have featureless retinas. If you look clinically, you may think that there are some hemorrhages, but it does not look too bad. But when you do the angiography, you'll see a totally different picture. And so these are the cases where you have to be extremely cautious. Featureless retinas, this is what will reveal much more in angiography. A case of a juvenile diabetic retinopathy, a patient had come to us treated elsewhere, recently lasered. You can see the whole laser, which is laser marks 360-degree, fluorid neovascularization for which the laser was done. And the patient has developed 360 choroidal detachments. This is one of the side effects of extensive laser that can cause choroidal detachments, effusions, and lead to visual loss. So this is a wide field image of a patient who had recently underwent laser, and we did angiography in this patient, and you can see what it looks like. There's extensive ischemia just beyond the arcades where this fluorid new vessels is, and of course you see the fresh laser marks which are there, which are manifesting. And of course, there's so much choroidal effusion that the whole picture is not very clear. But this is just one example of showing how extensive laser can cause. We always do PRP in sittings. We always do it in weekly intervals or 15-day intervals to avoid this kind of a situation in some of the patients who need extensive lasers. This is the late phase of the same patient. So these are some of the cases and where fluorescein angiography helps us interpret in detail how the diabetic retinopathy manifests and all the aspects of the diabetic retinopathy which are there. So initially, I gave you all the indications of fluorescein angiography in diabetic retinopathy. Now, today, as we stand, maybe we use a lot more OCT and clinical judgment to treat them. We don't use fluorescein for all sorts of situations for diabetic retinopathy. But if you ask me, two absolute indications. One is unexplained visual loss, which is where I'm suspecting macular ischemia. Fluorescein angiography is very useful. Of course, an OCTA may also be useful for something like this, and you could replace it with that. But the second one is recurring vitreous hemorrhage in a well-lasered eye. You've lasered, you've done everything, and now the patient comes to you with history of some hemorrhages which happened and cleared, or there is a fresh hemorrhage and floaters he's come with, and you see vitreous hemorrhage which is resolving, and you want to know where exactly is it leaking and where does the more laser need to be done at this stage in this situation. So that's when you want to define by precisely doing an angiography and knowing where exactly. In this case, you can see well laser, but you see these areas which are leaking, and you want to go and do much more laser to this area. Also, maybe give anti-VEGFs to regress this area. Thank you very much. Once again, I would like to thank Dr. Shraddha Srivastav, my VR fellow who's helped me collate these presentations, and all my fellows and optometrists who helped me take all the pictures of the patients that we treat and take these pictures from all these libraries and helping us put them together in this presentation. Thank you very much. The next one that I would do would be on other vascular pathologies such as vein occlusions, etc., apart from what we've seen with diabetic retinopathy so far. Thank you very much.